Good afternoon, everybody. Thank you, Dr. Mandal sir, for giving me this opportunity and including me in your IC. So I will start with the clinical evaluation and the surgical options for primary congenital glaucoma. So congenital glaucoma, as we all know, is a disease which is characterized by increased intraocular pressure due to isolated trabecular dysgenesis. But while we are doing the clinical evaluation of this patient, apart from the IOP related damage to the eye, we must take into consideration the other factors. Because the IOP measurement in infants and young children, especially during examination under anesthesia, is very difficult and it is potentially affected by many factors. So we should look for the other signs of glaucoma in this age group, like the evidence for ocular enlargement, the presence of the hub striae, and the increase in the cup disc ratio. So the Collaborative Glaucoma Research Network has classified the childhood glaucomas into the primary childhood glaucoma and the secondary childhood glaucomas. So in the primary category, we have the primary congenital glaucoma or PCG and the juvenile open angle glaucoma or the JOAG. Out of this, the primary congenital glaucoma is the most common form of developmental glaucoma, and it occurs due to isolated maldevelopment of the trabecular meshwork. It is not associated with other developmental ocular anomalies or ocular disease. So what are the aims of evaluation of a child with primary congenital glaucoma? First of all, the aim of evaluation is to confirm the diagnosis that it is indeed a case of glaucoma and not something else. There are mimickers of glaucoma, as we shall see. And then we have to identify what is the etiology of glaucoma, whether it's a primary congenital glaucoma or secondary glaucoma due to some other cause. Then we have to establish the baseline parameters for this child, like what is the intraocular pressure, what is the horizontal visible corneal diameter, what is the baseline cup disc ratio, what is the visibility of the structures, and so on. Then depending on these factors, we have to assess the severity of the disease and the prognosis of this particular child. We have to also take into consideration the ocular and systemic comorbidities, and very importantly, we have to rule out any space occupying lesion, for example a retinoblastoma, which can be a dangerous mimicker of primary congenital glaucoma. Regarding the history, the age of onset of the symptoms and signs, and then as we all know, the classical symptoms of primary congenital glaucoma as is described in Western textbooks are epiphora, photophobia, and blepharospasm. But in addition, the children that we see in the Indian subcontinent can come with corneal haze and ocular enlargement. Rarely these children can present with red eyes which mimics conjunctivitis. We should also inquire whether the mother had any problem during pregnancy, example rubella, and these children have a sort of have a variety of other problems, for example hearing deficit and so on. Then delivery history, particularly use of forceps, because forceps injury can also produce some changes in the cornea which can mimic the hub striae. Then the family history, because we all know that the parental consanguinity is an important risk factor for primary congenital glaucoma, and any presence of glaucoma in the siblings. So we are discussing this, that most Western textbooks describe a classical triad of epiphora, photophobia, and blepharospasm, which is attributable to the IOP-induced corneal epithelial edema. However, in the Indian subcontinent, many of the children that present to us actually come with symptoms of a large eyeball size and hazy eyes from corneal edema. Rarely, children can present with acute corneal hydrops. That is one of the rare presentations of primary congenital glaucoma also. Now, while assessing these children, vision has to be assessed by age-appropriate methods. Then the most crucial thing of assessing these children is the examination under anesthesia, where we have to do the following things. We have to check the refraction, we have to look at the corneal findings, measure the intraocular pressure, do a gonioscopy, check the fundus, and based on these findings, we have to decide for surgery. And in many cases, the surgery and the EUA is done in the same sitting. So what are the prerequisites for examination under anesthesia? A good pediatric speculum, fluids for irrigation, calipers, tonometers, ideally the Perkins tonometer, but the tonopen and the eye care are also good options. Direct and indirect ophthalmoscope, retinoscope, a gonio lens, ultrasound pachymetry, and B-scan. Now, what is the choice of anesthetic agent? In short, the type of anesthesia and the type of tonometer are important. all anesthetic and sedative agents lower the intraocular pressure excepting ketamine, chloral hydrate, and benzodiazepines. The most commonly used inhaled agent is sevoflurane because it's very convenient and it has a safe profile. And the most important thing for ophthalmologists is that the intraocular pressure should be recorded just after the child stops moving after inhaled anesthesia and prior to intubation, or else we will get erroneous results of intraocular pressure. So the intraocular pressure is usually measured by Parkin's tonometer. Tonopen can also be used, but it has been seen that it slightly overestimates the IOP compared to Parkin's in normal children and in those with glaucoma. The iCare portable rebound tonometer, it has an advantage in that it does not require a topical anesthesia. Ideally, we should use the same instrument for follow-up, and I would again stress that the IOP should be measured as soon as possible after the initiation of the inhalation anesthesia and prior to intubation. The corneal haze is important because it's representative of the severity of the disease. Usually the corneal haze in primary congenital glaucoma is more in the center, and the clarity of visualization gives us some idea as to the severity of the disease, like whether you are able to see the pupillary margin or the iris details or the fundus vessels. Initially, the corneal edema is a simple epithelial edema due to elevated intraocular pressure, but subsequently develops into a permanent stromal edema. That is why the sooner that these patients are treated by surgery, the better it is. Untreated, the edema progresses to stromal scarring and irregular corneal astigmatism. Now, it's very important to measure the corneal diameter and to document the findings. The corneal enlargement secondary to elevated intraocular pressure usually occurs before 3 years, and for anatomical reasons, we usually measure the horizontal visible corneal diameter, or the HVCD. It's a wide to wide diameter that we measure. It's important to remember the normal findings. The normal finding is about 10 millimeter at birth, and the abnormal findings will be greater than or equal to 11 millimeter in the newborn, more than 12 millimeter in a child of less than 1 year of age, or more than 13 millimeter at any age. Then corneal striae, the hub striae are due to ruptures in the Descemet's membrane. Their characteristic in primary congenital glaucoma is that in the periphery they are concentric to the limbus, but when they are usually located centrally and are typically horizontal, and they can cross the visual axis. An important differential diagnosis of hub striae are the ruptures of the Descemet's membrane that we see because of forceps injuries. These, on the other hand, are vertical, unilateral, central. Children have congenital normal corneal diameter, and there is often periocular bruising due to associated injury to the adnexa. Then gonioscopy can be done and should be done when the cornea is clear. It has to be remembered that in the normal newborn eye, the iris has recessed beyond the scleral spar, so the scleral spar is visible as a whitish band. But in contrast, in primary congenital glaucoma, the peripheral iris inserts through the trabecular meshwork and the scleral spar is not visualized. Then the fundus has to be evaluated, the child has to be dilated, and we have to assess the general fundus and the optic disc. So we should look at the cupping and focal areas of rim loss. As a gross measurement, a cup is to disc ratio of more than 0.3 in a child or more than 0.5 in an older child is suspicious. We should also look at the peripheral retina because choroidal hemangioma can occur in Sturge-Weber syndrome, pigmented retinopathy can occur in rubella. And one important thing to remember is that after successful surgery and reduction of the intraocular pressure, there may be a striking reversal of cupping with IOP reduction. Then pachymetry can be done because it can influence the accuracy of the Goldman applanation tonometry, but the definitive role of pachymetry in the evaluation of childhood glaucoma is uncertain, and the CGRN recommends that the CCT should not be used to adjust an IOP measurement, but it should rather be taken into consideration in the overall context. Regarding the axial length, the absolute value may not be that important, but we should remember that the axial length usually decreases after surgery, and even after surgery, we should follow up these children, and if we find that at any point of time the axial length is increasing after surgery on sequential examination, then it can be a sensitive indicator of progression of glaucoma. The B scan has to be done in absence of good view, and it can provide critical information about the space of coagulations. And there has been instances where retinoblastoma has been mistaken for primary congenital glaucoma. So we should always take into consideration that there may be other differential diagnosis of this enlarged eyeball or corneal clouding. So there are a lot of differential diagnoses of congenital corneal clouding. This study listed the common differential diagnoses like Peters anomaly, sclerocornea, dermoid, congenital glaucoma, and birth trauma and metabolic disease. So the mnemonic to remember is STUMPed. S stands for sclerocornea, T stands for tears in the Decibels membrane, U stands for ulcer, M stands for metabolic corneal opacities, P for the posterior corneal defect, E stands for endothelial dystrophy, and D for dermoid. Coming to the basic guideline for the surgery for primary congenital glaucoma, which will be more elaborated by sir and madam. So surgery is the mainstay of treatment and is almost inevitable at some point of time. Initially we can start with an anti-glaucoma medication, but that is just to buy time till the child is ready for surgery. And the first surgery has the best chance for success. Preferably the surgery therefore should be performed by a trained surgeon with adequate surgical skill and experience in managing congenital glaucoma, and it should be done in a very safe anesthetic setup. And in general, the primary congenital glaucoma surgery or glaucoma surgery in children is more challenging than adult glaucoma surgery. So what are the surgical options that we have? Initially, the first surgery described was goniotomy in 1940s by Barkan, then trabeculotomy ab externo in 1916 by Burian and Smith. Then trabeculectomy was described for adult glaucoma by Cairns in 1968, and subsequently it was done for pediatric glaucomas also. Then combined trabeculotomy with trabeculectomy in 1979. Then due to advancement of technology, a lot of new procedures have been described, like a 360 degrees trabeculotomy. It was initially described by Peck and Lynch in 1995 using blunted 6-0-proline. Then endoscopic goniotomy in 1997, but it did not become very popular. Then fiber optic microcatheter trabeculotomy was described in 2010. And Dr. Mandal will recently show his innovation where he has combined this technique with trabeculectomy. And for recalcitrant cases or cases where the IOP has again gone up after initial surgery, you have the tube shunt implants and the cyclodestructive procedures. Some general considerations regarding surgery. The angle surgery, that is goniotomy and trabeculotomy, is the procedure for choice for primary congenital glaucoma. Out of this, which one to choose, goniotomy or trabeculotomy? This has to be decided by the surgeon, and the exact choice is dictated by the corneal clarity, the surgeon's experience, and the surgeon's preference. The anatomical factors that decide this choice are the corneal clarity, because if it's a clear cornea, we can think about goniotomy. It's an opaque cornea. Goniotomy cannot be done. It has to be either a trabeculotomy or a combined trab and trab. And if it's a skirt conjunctiva, then a tube has to be done. The success of angle surgery, that is either goniotomy or trabeculotomy, is high in favorable cases, as high as 70 to 90%, and is thought to be determined more by the severity and duration of the disease rather than the type of surgery. Thank you. That's just an overview of the clinical evaluation and the basic approach towards surgery, and this will be more detailed by Dr. Shushmita Kaushik and Dr. Mandal. Thank you.